From the JAMA Network, this is JAMA Internal Medicine Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinions featured in JAMA Internal Medicine.
Hello and welcome. This is Dr. Eve Rittenberg, the Viewpoint and online editor at JAMA Internal Medicine. Today, we're talking about the problem of potentially harmful medicines for people with dementia and how challenging it is to stop these medicines once they're started. So unlike a lot of studies where we look at which medicine is best, here we're talking about the opposite. So how to deprescribe risky medicines that might not be needed. So really how to do no harm. And the study that we're going to discuss today examined whether information given to patients or to prescribing clinicians might achieve this goal. So I'm looking forward to talking with our guests today. Dr. Jerry Gurwitz is the senior author of a paper titled Reducing the Use of High-Risk Medications in Persons Living with Dementia. Dr. Gurwitz is a professor of medicine at UMass Chan Medical School. And we'll also chat with Dr. Ariel Green, the author of the commentary Start Upstream, Leverage the Team, Deprescribing in Dementia. Dr. Green is an associate professor of medicine at Johns Hopkins University School of Medicine. So welcome, Dr. Gurwitz and Dr. Green. Jerry, can you tell me why you got interested in this topic of deprescribing medicine?
Sure. And thank you, Eve, for the opportunity to be here today with Ariel. Polypharmacy in older adults is a real issue. And it's an issue because for many drugs, the risks can outweigh the benefits. And sometimes older adults are on medications longer than they are needed. That's the case for the types of drugs we studied in this trial.
So were there particular medicines that you thought were so potentially harmful that that's where you wanted to focus?
Yeah, I think our focus included these drugs because the risks can outweigh the benefits. And we're talking about antipsychotics, sedative hypnotics, and strong anticholinergics. And they can be of even greater risk in older adults with dementia, which was our target of this study.
So tell us what you actually studied in terms of how to approach this problem.
Yes, so our research team set out to determine whether a low-touch, mailed educational intervention to patients living with dementia and their prescribers could be effective in encouraging deprescribing of these drug classes.
When I read your study, which was mailing an educational brochure, I kept thinking, wouldn't it be so nice if these brochures worked? It's so easy. You know, it would get us clinicians out of some really tricky conversations with patients, but turns out it wasn't so easy. And so I wonder if you can tell us what your key findings were.
Yeah, for sure. That was our hope. And that was our assumption in this trial, that a low-touch mailed intervention would work. And that mailing educational information to the patient would stimulate them to reach out to their physician or their prescriber. That mailing educational intervention to the prescriber would encourage them to reach out to the patient, and everything would be great. And unfortunately, that wasn't the case. We had 3 arms of the study. In one arm, both patients and prescribers received the mailing. In the second arm, only the prescribers. In the third arm, neither patients nor providers received the educational mailing. And what happened? Well, absolutely nothing happened. In all groups, the percentage of people continuing on the targeted therapy for deprescribing was exactly the same. Very discouraging.
Wow, really discouraging. So let's turn to Ariel, because in your commentary, you talked about some of the reasons potentially that this trial didn't work, even though there had been some indications in previous studies that there might be some decreases in inappropriate prescribing. And so I wonder if you can talk about some of the reasons that it might have been so hard for this to succeed.
Sure. So I think, first of all, patients with dementia are an extremely challenging population. The previous deprescribing interventions that seemed to work in Canada, for example, were not focusing on patients with dementia. We're actually excluding patients with dementia. And so I think some of these medicines, like the antipsychotics, are often being used because both families and clinicians don't have access to practical, effective, non-pharmacologic strategies for dealing with very challenging problems. Sometimes these medicines are being used because it's just hard, especially in a busy practice setting, to offer and explain these non-pharmacologic alternatives. Sometimes they're being used after a thoughtful decision-making process as a last resort. So I think that's one reason, is that this is the most challenging population probably to deprescribe in. The second related reason is that deprescribing, especially in this population, really depends on meaningful conversations. I think patients and families, we've learned from qualitative research, is that patients and families really need to have these conversations about risks and benefits of medicines in the context of their priorities and their preferences with clinicians. I don't think that necessarily has to be the prescriber. It could be, for example, a pharmacist, which is why I talked about the interdisciplinary team. But I think the desire to do a pragmatic intervention and do a mailing, we all hope that would be effective. But I think we're battling so many factors that we really need a little bit more intensive intervention, I think.
Does a negative study like this help us know what might be helpful instead? Does this help us focus on other places?
I think what we can learn is that for this challenging population, we need more than a single mailing, even though this was thoughtfully done with a mailing to patients and care partners, as well as a nudge for clinicians. But I think there's so many challenges that I think the conversations are really what are important. So I think this tells us maybe, focus on the conversations on the interdisciplinary team. I think the other thing that we can learn from this is that we may be starting too far downstream with deprescribing, and that it's especially hard to get patients off of these medications. And we need to be doing more upstream. Another thing we know is that from qualitative research and surveys is that patients really trust their clinicians and want to hear about medications from their clinicians. And so I think anything we can do to try to get clinicians to have conversations about safe use of medicines before we start these medicines is really necessary.
It seems like you're sort of in a tricky situation, though, if what you really need is quality time with the patient and their family potentially and the clinician. But at the same time, there's so many asks of clinician time these days that you want to offload some of it, into team-based care or into these mailings or other places. And so it seems like it's especially important to figure out which of those functions can be taken away from the clinician and what has to stay there.
Yeah, I think that's a great question. I mean, I do think more research into, as you said, what aspects of the conversation could be taken away from the clinician and had by other members of the interdisciplinary team. I think that would be really useful. There could still be a place for low intensity interventions like mailings, but just further upstream. I think culture change is really important. I think we are, especially in this culture where patients and families are being bombarded by ads and other things that typically are encouraging medication use or encouraging interventions. And so I think if we could flip that and get some of the upstream education that's going out to patients and families to be about the idea that sometimes less is more, sometimes non-pharmacologic interventions are safer and better for you, that would go a long way too to sort of set the stage.
And Jared, so Ariel has talked about a few next steps that might be useful in this field. Do you have thoughts about what, particularly in the research field, some exciting next steps might be?
Yeah, thanks, Eve and Ariel. I think the starting point for us is in the context of a failure, what the lessons learned are. And just following up on your comment about primary care physicians being overwhelmed, we were pretty certain from the get-go that letters just to the prescriber would have no effect. And our hope had been that the secret sauce of the intervention would be the patient and possibly their caregiver receiving the information, and that would stimulate a conversation with the prescriber. Well, that didn't necessarily happen. And I think the question is what the role of the prescriber is in all this. And I think Ariel and I agree that it's really important. Patients and their families trust their clinicians. And I think the big issue here is that these are complex clinical scenarios that can't be dealt with just a nudge or a cue or a letter. It's got to go deeper than that. So I think the approaches that I understand Ariel's taken really relate to a healthcare team in a more intensive intervention and specific targeting and priming. I think all those things are probably necessary.
Yeah. And also to get back to Ariel, what you were saying about a culture change. So one thing that stood out to me, Jerry, from your findings was that more than 3/4 of the individuals with dementia prescribed at least one of the high-risk medications. I mean, that's the vast majority. And so that sort of normalizes that these medications are safe and beneficial and everyone's taking them. And so it does seem like there really needs to be a culture shift in order to make it feasible to start deprescribing.
The use of these medicines is highly prevalent in this population for sure. And this is a community-based population. So the question is, are prescribers just routinely prescribing these things? Or are the situations so complex, so challenging that the patient, the family member, the prescriber doesn't have an alternative? Because Ariel and I are both advocates of non-pharmacologic interventions. And that's the missing piece here.
Yeah, interesting.
And I do think it's likely some of both. Like, I think the mailing in this intervention probably captured some patients where it was a busy clinic visit and they were faced with a challenging situation and they probably prescribed something without a lot of conversation. But I think there were also probably a lot of patients where there was a thought process and a conversation, and this truly was a last resort. So I think that's another part of what we're seeing is that, I don't think we know the right rate of prescribing of these medicines. We all think that it should be lower. But I think in some cases, these medicines are actually being prescribed probably appropriately as a last resort. So I think deprescribing will always need to be a shared decision-making process. And that may, in fact, be a better outcome to measure than just the number of medications or the more distal things like falls and hospitalizations. But I think for patients with dementia, as Jerry mentioned, these clinical situations are so complicated that measuring the decision-making process or whether the medications are aligned with the patient's and the family's priorities and preferences, I think those are important outcomes as well.
Great, thank you. We're sort of nearing the end of our time, but if you have one clinical pearl for people who are clinicians working with individuals with dementia who are in this tricky situation, is there one thing you recommend or one thing that you think people should know?
I'll mention two things. One is that these are very complex situations. I'm convinced prescribers have to be involved and have to have enough time to do it right. This is not a clinical pearl, what I'm going to say next. But I think there are lessons for national health plans that just sending letters to patients and physicians and prescribers really is not a great way to improve the healthcare of their members. And it's like health plans sometimes feel like they're checking off a box and getting something done that's important. And these communications have little, if any, impact. And the final thing I'd say is if a health plan sent out a letter, then followed patients like we did without a control group, the health plan would believe that the letter led to deprescribing in 30% of patients. So that's what often happens. These interventions by health plans are like reinforcing that they're doing a good thing, but they're really doing nothing.
That is such an important point to make and such a plug for the value of trials like you did to give us the real information. So it's been so interesting talking to both of you. And I'm Dr. Eve Rittenberg, the Viewpoint and online editor at JAMA Internal Medicine. I've been speaking with Dr. Jerry Gurwitz and Dr. Ariel Green about deprescribing medications in individuals with dementia. And you can find a link to the articles in this episode's description. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. This episode was produced by Daniel Musisi at the JAMA Network, and thanks for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.